logistics. We can't accept any sort of questions or anything from our online audience, but I'm really grateful for everyone attending, if they can hear me, which I hope they can. So let me introduce myself. My name's Dr Simon Opher. I'm an MP for Stroud in Gloucestershire, and I've also been a GP for about 30 years, and I've worked from about about the year 2000 with an artist in my surgery, and I'm very engaged in this, and I'm really delighted so many of you can attend this event. So what we're thinking, so I'm sure you're aware of this, but the government in its NHS plans is thinking of 3 shifts. So the first shift is from hospital to community care. The second shift is from cure to prevention, so a sort of left shift, which I'm sure many of you understand. And the third shift is from analog to digital, so make the NHS offering much more digital in its nature. And so all those 3 things actually impact on this round table, but it's specifically around using creative health in the digital sphere. So that's why you're all here, and that's why we're going to have a discussion. And the idea, we had over 30 expressions of interest in this, so I'm really glad that we've got 9 particular presentations that we're going to have. And then after about an hour, we're going to open it to the floor and have another hour of questions, discussion, etc. So could I just warn you, you've got about 7 minutes each, so I'll start waving my pen and stuff like that if you're going on a bit long. So I do apologise for that, but obviously we need to squeeze it all in that way. So as I said, the National Centre for Creative Health, with Alex at the helm, has had a call out for case studies. And so I'm really excited about what I'm going to hear this afternoon. And I won't go on very long because I want to hear from you guys. But what we will do at the end is we'll develop from what you've said and what the audience says, we'll develop a policy brief around what we can offer in the digital space around creative health. And I will send that to number 10 because I know that there are the Special Advisor for Health in number 10 is very interested in our digital offer. She was invited, but she can't come this afternoon, but I said I would send her that. So it will go right to number 10, and so they will get information. Whether they do anything with it is something that we have to work on, but so we're not talking for nothing, that's what I'm saying. So this is important stuff. Okay, so can I start off then with Giovanni? And I think everyone should have a biography of them, so I won't go on. All I'll tell you, Associate Professor in Bioengineering at the British Heart Institute. So would you like to go first?
Yes, no problem. Thank you very much. Good afternoon, everybody. I'll share my time with Sofie, and we'll be careful to stick to time. I was going to start with the NHS shifts that have already been mentioned by our chair, so we'll not repeat, but I'm really excited as a biomedical engineer, interested in the arts, to be talking about digital creative technologies. So just to contextualize it to our work, and I'll speak in the plural because I share all of this work with Sofie, as I said, and a big team of collaborators as well. When we talk about digital creative technologies, starting from the end, what technologies are we talking about? In our case, we predominantly work with imaging technologies and 3D technologies. So just to contextualize, it's a lot of that, so implicitly digital, but not only. There's a physical side to it, which is through 3D printing and additive manufacturing methods, we can make what we say the visible tangible, where the imaging makes the invisible visible when we think about the body. The creative element applies both to process and output, in the sense that a lot of the work that we've done is underpinned by a creative process, which could take the form of participatory practices and work with patients, and the output in the sense that the presentation of the output, be it physical or virtual, is creative and is created with or by entirely artists. And then the digital side is maybe more intuitive, but it applies to both source, medium, and output as well. Source in the sense that the imaging data is just this immense amount of digital information that we have, and we all get imaged, and more so as part of also the shift to prevention. The medium in the sense that the imaging is the source to make the 3D realities that then we work with, and is the starting point for some of the creative work. and the output in the sense that some of the digital artworks themselves are digital, be it virtual reality experiences or mixed reality or digital animations, for example. So within this context, Sofie, myself, and other collaborators have been working for over 10 years to develop what I call an ongoing program of work. It started in the context of pediatric cardiology specifically. I think some of the best things start through coincidences, in the sense we found ourselves in a context of pediatric cardiology research, and we started working with young patients who have congenital heart problems, and that work was incredibly rich. And as I said, we're still working in that space, but it's also growing. So as we have developed the methodologies, we now are doing some work on kidney cancer, we're exploring orthopedics. So I think, although this work is very sensitive and complex and cannot just immediately be translated to different scenarios, we are exploring through new collaborations how to apply some of these methods beyond the pediatric context and beyond the cardiology context. And as another role that I have is the director of the Lived Experience Network that works very closely with the NCCH. And what I want to stress before handing over to Sofie is the way in which patients' voices are, well, the starting point of the work, but also carefully, sensitively embedded in the process, so in the making and in the outcomes and outputs themselves, where these outputs can be presented both in NHS context, as in, for instance, literal art installations in hospitals, but also there's something very, I think, possibly underexplored at the moment that goes to health messaging and innovative health messaging that I've now noticed the NIHR is speaking on. So that's exciting in my opinion. And on that, I hand over to Sofie.
Thank you very much, Giovanni. I'm just going to read, so it keeps me on track. So my work is as a socially engaged artist, researcher, and I work with people's lived experience to develop artworks in response to patient stories within the medical landscape. Diagnostic processes increasingly rely on data-driven imagery, which can leave individuals feeling confused and alienated. However, when this data is creatively translated, it can become a powerful metaphor, a narrative metaphor even, which functions as an integral part in an individual's engagement with their own health journey, which may be used for wider public engagement. And by way of example, the Heart of the Matter project, which was a culmination of work with in 2018, was a Wellcome Trust and Arts Council funded public engagement project incorporating individuals and collective heart narratives from over 100 patients and participants. It culminated in a national touring exhibition exploring the poetic and medical dimensions of the heart, literally making the invisible visible and tangible through the creative translation of medical imaging data. However, these creative translations can only happen when patients are provided with the creative tools and a landscape which facilitates and supports people to think through their medical condition in a non-medical way. And by way of example, while I was at Great Ormond Street, a mother, when handed a 3D print of her baby's heart, and here I have not the heart, but a representation of that, the mother said, "I feel like I'm holding snow in my hands." The vitality of her young child's congenital heart condition was captured through the artistic exchange with the medical data, which in the next moment became re-medicalized when the nurse in the intensive care unit showed her where her daughter's operations could be seen within the heart model. 10 years later, in a recent social media post, this mother acknowledged the importance and impact that the art project had had on her and her daughter's medical journey and their family's well-being. The creative transformation of medical data and imagery can take numerous forms, from VR animations, creative film work, but also delicate artworks made as tactile 3D printed sculptural votive forms, some of which I've brought with me today. So there are some beautiful bronze hearts and blocked hearts and kidneys which maybe at some point we can just cast our eyes over. And by employing digital data from the beginning, middle and end of life, and working creatively and ethically with this data, I think there is the potential to be it has the potential to be transformative for patient understanding and their future health and well-being.
Thank you. That's really fantastic. I'd like to have a look at that at the end as well, so that'd be really useful. So next, can I go to Kiz and Ellie? Is that right? And you're so Mortal Fools is your organisation. So explain more. Yeah.
Nearer the microphones. I'm sorry, it's in the room, but apparently they can't hear it from TV. So
okay, sorry.
I'm leaning forward as I speak. Thank you.
Yeah, those microphones there. Just lean it as close as you can to them.
That's fine. I shall use my theatre projection to reach the microphone.
Much better, yeah, that's good.
There we go. Hello everybody, my name is Crosbie. I'm the Artistic Director and the Chief Exec at Mortal Fools. We are a theatre, drama and creative learning company based in the northeast of England. We believe that arts and culture organisations should provide a public service and be playing their role in supporting people to flourish by working to address some of society's key challenges. Mortal Fools specialise in using participation in creative activities as a method to help people develop knowledge, confidence, healthy relationships and skills for life, with a particular focus on work with children and young people. So today I'm going to talk about our multi-award-winning Melba Digital programme, so how we use digital tech to support the mental health of thousands of children in the northeast. Take a moment to imagine a child. She's 10 years old. She loves to wear her red wellies. She likes eating sweets, going on adventures. She regularly talks back to the grown-ups in her life. She's a pretty typical adolescent. But this 10-year-old child also struggles with anxiety. And she's now reached the point where she has regular angry outbursts, refuses to do the things that she's previously enjoyed, and it's a struggle to get her to leave the house at all. And this child doesn't have the tools to help herself, and critically, neither do the adults in her life. This child is Melba Mapletree, the protagonist of the stories in our Melba Digital programme. The development of this programme was a direct response to the 2017 white paper transforming children and young people's mental health provision. Melba Digital is a web-based, multi-art form programme for supporting the mental health of adolescent children, the age that research indicates as the starting point for around 70% of adult mental health conditions. We train their primary school teachers to deliver the programme in schools, usually as part of PSHE, and it's suitable for all children, not just those that are struggling. Melba Digital uses the process of taking part in different creative activities, an animation series, a feature film, a choose-your-own-adventure style storytelling game, that's a mouthful, isn't it? And an illustrated novel to teach children about mental health and well-being, and more critically, teach them the skills to better manage their own emotional and mental health, setting them up for much better lifelong mental health. So why is this important? We're in the midst of a national crisis for children and young people's mental health. Public Health England estimated in 2023 that 1 in 5 children and young people aged 8 to 25 had a probable mental health condition, and that doesn't account for any low-level struggles. Children and young people's referrals to NHS mental health services tripled nationally from 40,000 in 2016 to 120,000 in 2024, and this rate is not improving. In our home turf in the northeast, we have the second highest children and young people's mental health need prevalence in the country, 15.6%, versus the national average of 13%, with 3/4 of children who need help either waiting so long that their condition worsens or they never get help at all. Last year, the ONS stated that suicide had become the most common cause of death of young people under 35 in the UK, with rates having increased by more than 50% in the last decade. Let's make no mistake, we are in a crisis. The old systems are simply not serving these needs. But let's talk about hope. The renewed focus on early intervention and prevention in the NHS 10-year plan was a very welcome shift in approach. Our work, including the Melba Digital Programme, teaches people how to regulate their emotions. And learning to regulate emotions is not just about improving people's health in the here and now. Teaching emotional regulation is crime prevention, it's addiction prevention, it's suicide prevention. And so the economic argument is compelling, with research indicating cost savings to the public purse of anything between £3 and £8 for every £1 spent on early intervention and prevention. As a creative organisation, we're skilled at innovating and pioneering new ways of doing things, and our children and young people need new ways of doing things more than ever before. But we cannot do this alone. We need to be pioneering new approaches across agencies and sectors. So how have we been doing that in the North East? For 3 years now, we've worked in a commissioning partnership with the North East Combined Authority. Through their Excellence in Education programme and Child Poverty Reduction priority, the Combined Authority has provided £135,000 of investment per year to support the distribution of the Melba Digital Programme to primary schools across that region. This has allowed us to provide the programme to the region's schools without charge, going some way to addressing the inequality of access to resources like these. Its digital format means that it's widely accessible to schools across the region. To date, it's been used by over 150 schools across the 7 local authorities in the North East, with around 10,000 children accessing the programme this academic year. And several years in, we know this programme works. From feedback from teachers and the children themselves, we know that the programme engages them, the stories and the characters feel relevant to them, and we know it improves the confidence and the skills of teachers in supporting children's mental health. And the impact data from the programme is also compelling. Last year, 94% of children demonstrated improved understanding and knowledge of mental health. And critically, as a prevention tool, 99% of the children demonstrated increased knowledge and capabilities in self-management tools. With the current distribution scale, the £135,000 investment from the North East Combined Authority translates to a delivery cost per head of only £13.50 per child, for a minimum of 8 hours of directly delivered activity. 8 sessions of directly delivered activity for less than the cost of a single appointment with a mental health services provider. So what do we need? In short, we need investment. We have a digital programme we know that the children are engaged by. We know it produces the outcomes and impact we set out to achieve. From our work in the North East, we know it's suitable for commissions because it's digital, it's sustainable. And with the right level of investment, it could be distributed at a significantly greater scale than resources allow us to do currently, branching into other regions and nationally. The current programme format is designed to be delivered in schools. With the right investment, we could reformat the programme to become a digital resource to be used by families, prescribed by clinicians, by children and their families with resources to support themselves and reduce their reliance and pressure on NHS services. Thank you.
Thank you, Liz. That's fantastic. Yeah, thank you for that. And I'm sure there'll be lots of comments, lots of alarming statistics about children's mental health there as well. So thank you for that. Lisa, could I come to you? So you're from you're the artistic director of Small Things Dance Collective from Alder Hey Hospital, is that right? All right, over to you then.
Everybody, so
Yeah, lean close then in that case.
I'll move closer.
Yeah.
So we are in our 20th year of dance development and research as part of Alder Hey Art for Health. Our multi-stranded project has developed from our ward-based one-to-one work. As dancers, our process is informed by improvisation, somatic practices, and instant composition. This means that we don't teach steps. We attune kinesthetically to the individual, creating dances, movement, play, and shifting states in the body, which might also include bringing children into rest and relaxation. This inclusive person-centered approach has led us to work on acute wards across the hospital with children who have life-limiting and life-threatening conditions. We are currently working on oncology, burns, cardiac, and neuromedical wards. We've been on cardiac and neuromedical wards for almost 20 years, 2 days a week, and we see children and young people experiencing pain, fear, anxiety, fear of moving, isolation, and boredom. We have a performance strand, which also includes performing in public spaces and internet bedside performances for children who are unable to leave their bedrooms. The research suggests that watching dance evokes kinesthetic empathy, which can be loosely defined as a sensation of moving while watching movement. These concepts have also been studied in relation to screen dance, and there is some evidence that watching screen dance and discussing it with others might stimulate kinesthetic engagements. So the idea for our VR shifting landscapes project followed a project we completed during the pandemic, where we had socially distanced performances with nature-inspired films projected in the children's bedrooms on the walls and ceilings. And we learned that bringing nature into a clinical space alongside performance is very calming and enjoyable for patients and their parents and carers, with reports given like they'd left the hospital and connected with nature. So for this new project with Twin Vision Media, we created an immersive experience 360-degree dance film with binaural sound set in 2 remote landscapes, one forest and one on the coast. They're very slow-paced thematic movement explorations in the landscape, and we had in mind the kinds of children that we work with, children who are in pain, children who are withdrawn, anxious, and bored. So how we use it is we have this 2-day residency at the hospital, and we have the VR headset as part of our toolkit. So we take it onto the ward and we use it when appropriate with children. We've used it with children recovering from brain injury, children and young people with extended stays on cardiac. For example, a long-term patient on neuromedical who had previously been very active and was struggling with her mental health watched the Oscillate speech film. She said while she was watching it, she was smiling, laughing. She was describing to us what she was seeing or doing in the film, and she said she wanted to go to the beach and roll down the sand dunes. Afterwards, she wanted to get out of bed, which was remarkable because she hadn't got out of bed for quite a long time. So we facilitated that and supported her in her movement. So it's as if something had been activated in the sensory motor pathways through watching this film. Her consultant, Dr. Mary Boulier, offered her feedback. So I quote, a teenage patient who had had a long admission over a few months and was unable to mobilise found the VR helpful to be able to relax and feel like she was able to experience somewhere different to the hospital environment. The team who provided the VR experience helped her to build confidence and boosted her mood. Another long-term patient I've been working with who's also had orthopedic surgery and is unable to move and experiences pain, which she verbalises frequently, really settled when watching the film. His focus shifted, he stopped expressing pain, his breathing changed, and he was completely calm. And afterwards, he was much happier and quite sleepy. And I did some relaxation and he fell asleep. So we use it in this way. And in addition to us facilitating these experiences, we've had support from the technology and enhanced learning lead, Russell Ashworth, to widen the reach of the project by introducing it to other teams. So it's in use by the play team, and Amanda Walker, senior health play specialist, explains how they use it. She says it works particularly well for children over 6 who are having blood tests or electromyopathy tests, helping to distract them during medical procedures. I've also used it within the emergency department to still simply help calm some patients who are distressed on arrival. And finally, an exciting and very unexpected new collaboration has emerged for us throughout this project with the dentistry department. I didn't even know where dentistry was in the hospital. I do now. So they've really taken it on, and I'll let Laura Shutter, dental therapist, explain how they use it and what would be beneficial for them in going forward with this idea. She says, I use the VR headset for patients undergoing dental treatment, particularly those who feel anxious. I work closely with children and young people with cleft and craniofacial conditions, and this technology can be very beneficial in helping them feel more comfortable during procedures. For example, Cleft patients often require teeth extractions prior to a bone graft procedure or further orthodontic treatments such as braces. Using the VR headset can help these procedures be carried out under local anaesthetic in the dental chair, allowing patients to return home shortly afterwards and potentially avoiding the need for a general anaesthetic. It would be helpful to develop more films to watch where the image is centred and takes on a journey of timings approximately 20 to 40 minutes long. So at the moment, our films are 15 minutes. They want the weekend ones. For carrying out centre treatment, it's important to ensure that we keep a head still while patients and keeping patients engaged at the same time. So I feel there's certainly more potential for us with our project at Alder Hay, bearing in mind Alder Hay sees 450,000 patients each year. And we feel like there's more mileage in developing further bespoke experiences of different lengths for different departments that clinicians can offer depending on the procedure that they will be using.
Great, thank you very much. That's fantastic. I'm gonna whiz round so that we can get lots in. So thank you for that. There's lots to comment on there. But can I go to you, Oliver? And you're Associate Professor in Animation at University of Greenwich. So welcome.
Thank you so much, and thank you, Alex, for the invitation. Creative health interventions and participatory art engagements can influence mental health outcomes, social cohesion, and reduce health service demand. Participatory arts are often defined as collaborative creative arts practices that actively involve the participants in a creative process. Over the last 50 years, from the Alma Mater Declaration in 1978 through the All-Party Parliamentary Report for Health and Wellbeing, awareness and understanding of participatory arts and its effect on health has much increased, but the role of digital, specifically in the context of creative health, has long remained under research. The rapid emergence of digital art platforms for creative health engagements now show promising results, and in our own HRC-funded study to participate, we demonstrate that these benefits were amplified through increased accessibility and scalability, addressing barriers of geography, mobility, and social isolation. The project focuses on 4 groups of beneficiaries: NHS workers, the visually impaired, people with complex physical and learning needs, and young people. The research aims to explore the vast potential of creative interfaces for pro-social behavior, as well as challenges around ethics and accessibility in the digital context. Led by the University of Greenwich with our partners Claire Grant from the CNWL NHS Foundation Trust and Professor Dominic Franklin from Brunel University, and research partners across different sectors, we were focusing on multimodal and cross-sensory potential of digital interfaces. Our case studies translated existing artworks into digital contexts, asking questions around design and facilitation. The first case study, Theme Color, conducted in collaboration with the Royal National Institute of the Blind, the Art Collective Anadema Group, and the National Gallery, translated 3 paintings in the National Gallery's collection into digital multisensory experiences that can be enjoyed collaboratively online. In co-design sessions with RNID, we focused on creating meaningful and accessible onboarding and offboarding experiences. Colors of the original paintings by Van Gogh, Van Eyck, and Monet were transformed into soundscapes and 360 visual abstractions. The onboarding experiences provided cultural context and positioning within creative health. Visually impaired participants navigated through these colors of the paintings as 360 visual sound experiences. And one participant reported, "I experienced Van Gogh differently. It was like I went to the theater, a very creative approach." And another participant said, "You could really sense it. I felt like I was within the actual art itself." In addition to the qualitative data, the quantitative analysis showed a measurable increase in social connectedness and well-being. Findings point to the challenges around accessible online facilitation, but also the vast potential digital interfaces hold for creative health. Case study 2, Theme Voice, was developed with the charity Joy of Sound that create music instruments with groups with disabilities. Together, we redesigned an existing physical artwork by the Art Collective Anadema Group into an online interface for sound visualization. Participants logged onto the digital platform, and while singing, they see their voice come to life, animating constantly changing 3D representations of their voice in real time. When 2 voices harmonize, these vocal harmonies are represented as geometric forms, inviting participants to discover relationships between their voices. We saw a sense of true transformative joy among the participants, and many of you will know this sense of joy from singing this out. As with the previous case study, the participatory artwork showed also a measurable positive effect on social connectedness and well-being, and the resulting interface now lives on as a lasting legacy on the Draw Sound website. Here too, issues around accessibility were foregrounded, specifically compatibility issues, the need for multiple access points, for clear onboarding pathways, and importantly, we had to reconsider ethics when working with participants with disabilities. How is consent being sought? How is or isn't data being stored? How is co-authorship being communicated? And how can we create safe and accessible online spaces for these participants from vulnerable groups? The final case study, Zeitgeist, developed with the SMU Neurocrate and Dr. Simon Opher, who is here, is a participatory interface for real-time visualization of flow mental states. Based on Dr. Rahman's research into flow signature patterns, the Zeitgeist interface encourages flow mental states by using predictive AI-based algorithms and real-time visualizations of these measures. Participants engage in an array of creative exercises while observing their own and their partner's flow states as mesmerizing visual forms, supporting what we call social flow. Questions around ethics, data anonymization, and accessibility were foregrounded. The study, developed with mental health experts at CNWL NHS Foundation Trust, indicated a strong effect on social connection, on well-being, on mood, and on flow. And Zeitgeist has now been selected as one of the NCCH case studies, so you can read up on it online. In order to assess our evidence, we drew upon relational mixed method approaches, and due to the limited size of 165 participants necessitated by the inclusive, accessible nature of the work, initial conclusions were analyzed hand in hand with nuanced qualitative feedback. We've shared our insights through guidelines for digital participatory arts, which we developed with accessibility experts Natasha Trotman and our PDRA Daniel Hickman-Tully and our partners, and these are available on our website, participatoresearch.co.uk. Digital is the future of creative health, transformative and engendering social cohesion, joy, and hope. And together with the participant consortium, we articulate the need for stronger focus on accessibility and ethics and the development of new platforms and tools. And to realize its preventative potential in the 10-year health plan, we must address these critical areas: infrastructure, evidence, and ethics. Yeah, so with evidence this compelling, our recommendations want to encourage that digital creative health becomes not a privilege, but a cornerstone of equitable preventative care accessible to all. Yeah, all the information, including our partners, are on our website, and I have the guidelines here if you're interested.
Okay, that's fantastic, Oliver. Thank you for that. Yeah, digital is a future. So that sounds sort of encouraging that we're discussing it. So can I come to Simon, who's CEO of Noise Solution, and also particularly to Felix, who's a previous participant. Thank you both for coming.
Thank you very much. I'm also going to project as well. I have that theatre voice. I'm going to present, and then Felix is going to share his thoughts and feelings about his experience of his work with Noise Solution. Noise Solution has spent over a decade delivering one-to-one music mentoring to some of the most vulnerable young people in the east of England. And it's used technology extensively to demonstrate its outcomes. Its ability to demonstrate those outcomes has led to it winning or being recognised in, I think, 25 national awards since 2019, because we have the data and we can demonstrate it in multiple ways. We work with young people for whom traditional talking therapies are often not really the right fit, not because those approaches are wrong, but because they weren't designed for everybody. I'd like you to, similarly to yourself, imagine, if you will, a young person sitting in a room making music, not being assessed, not being asked what's wrong with them, just making music, with someone who gives them agency in succeeding. Yet from that, every week, Noise Solution, we are able to demonstrate in real time that their well-being is measurably changing without feedback forms, without clinical assessment, without medicalizing or problematizing that young person who just needed to feel seen. We currently deliver in the region of 800 hours a month of one-to-one music mentoring across the east of England. The music we're talking about is hip hop, drum and bass, grime, techno, genres that belong to young people, that carry identity and agency for them. There's no set curriculum with us. The young person decides what they make, and the mentor's job is to give them agency in succeeding quickly. And their job is also to build a relationship with that young person, because it's relationships that actually make a difference. Every week, the young person records a short video reflection in conversation with their mentor about what they've made that week and how it's made them feel. It goes into their own private digital story, which is a secure platform we built that connects everyone around that young person to their trusted adults. Their mum sees it, their social worker sees it, their teacher sees it, not in a meeting, not in a report, not in a risk assessment, but asynchronously in their own time on their own device. They see the young person achieving something real, often for the first time in a long time. And the young person sees them respond. They feel the recognition land. That loop, making something, sharing it, and being witnessed by the people who matter isn't a nice extra. It is the mechanism. Our research demonstrates what it's doing is creating the psychological conditions evidenced as crucial for flourishing well-being. And because the young person is driving that reflection themselves, narrating their own progress in their own words, they begin to own the change. The reflection is therapeutic in its own right. And as a byproduct, every participant builds their own longitudinal case study in real time, capturing things a feedback form would never have thought to ask. The data doesn't interrupt the relationship, it emerges from it. Over 8 consecutive years, we've recorded consistent, statistically significant improvements in well-being to P.0001. leading to outcomes including re-engagement with education and avoidance of acute mental health admission. We were recently contacted by a young woman who emailed to say her mother had been told to expect her to be in acute mental health care for the rest of her life. She wanted to let us know that she just graduated from university. And she was clear it was this intervention that had made the change. That's not an isolated case. We have hundreds of those stories. An independent social return on investment analysis returns £12.55 for every £1 spent on noise solution. That analysis took a year by 6 independent analysts. So that's an estimated 11.7 million in public savings this year. And 94.5% of our income as a social enterprise is commissioned income. Commissions are funding this because the evidence supports it. Alongside live quantitative wellbeing measurements and with consent, we are already running AI-assisted qualitative analysis of those weekly video reflections. Our system identifies in real time what is changing psychologically, grounded in self-determination theory, one of the world's most well-evidenced theories around wellbeing and engagement and motivation. What it's doing from those transcripts is surfacing the quotes that matter. It tracks how the language around psychological needs shifts over time. That analysis is already happening. It's already informing our outcomes. However, similarly, we are acutely aware of the concerns around AI. That's why we've now built a second version. That second version solves the 3 problems that matter most when working with vulnerable young people and AI. Those concerns being data security, algorithmic bias, and environmental cost. Our new existing model is based on a small language model, not a large language model. What it means is there is no open AI, there is no large language model. Data doesn't leave our organization at all. There's no black box. Outputs are interpretable and they are auditable. It also has inbuilt bias mitigation filters that we built, informed by thousands of documents that are concerned with best practice around EDI. Okay, it filters everything through those first before it does anything else. It's also GDPR compliant. Its energy footprint is 70% lower than equivalent large language model processing. It even runs on its own. It even runs in a data center that's powered entirely by sustainable energy. That model's built, we are commencing testing. We think it points towards what responsible AI in health looks like in practice. If any of you organizations think about all of the unstructured data that you have in your organizations that you have anxiety around using AI with, we think we've solved that issue. The evidence that our AI system generates doesn't come from a survey designed around what a funder wants to hear. It comes from what young people actually say in their own words, in natural conversation about the things that are genuinely important to them. The system surfaces those quotes tracks how language around feelings and capability shifts over time, and generates that as reportable evidence automatically. That matters in a sector where charities are collectively spending an estimated 15 million hours a year reporting. I think we can all recognize that. We think the answer isn't less evidence, it's evidence that emerges from the work itself, where technology organizes and reports on that unstructured data. What we're asking for here is recognition in commissioning frameworks, not as a creative add-on, but as digital health infrastructure. The 10-year plan already calls for the exact shift that we already represent: analog to digital, hospital to community, treatment to prevention. An 8-year evidence base, I think, deserves contract lengths to match and a seat at the table from the start. I want to end where we always start as an organisation, not with a number and not with a framework, but with a person. So I would like to hand over to Felix.
Yeah, so before Noise Solution, I was in quite a dark place mentally. Managed to drop out of college twice in about 6 months, which is impressive. And I just wasn't responding to traditional education or mental health services. I was referred to Noise Solution, able to secure funding. And straight away, I could tell the place where I needed to be. Just super casual. I was actually working with Simon. Just felt like we were hanging out. It was non-clinical, and it gave me a lot of independence and confidence in creating my own music, which was something I was interested in music. I'd always loved music. I'd never really pursued it in the way of just creating my own stuff. The whole digital stories thing was really great. Having the all of the work I'd created online, I could sit there with my mum, we could go through it, we could watch the feedback videos, and she kept saying to me, it was great seeing me smiling and laughing, which she hadn't done for years. After the course, I got a job, which was sort of playing on the confidence and the strengths I'd found within the solution, which was never on the table before that. I didn't want to work at all. And I now work full time in the motorcycle industry as a social media content creator, and I love what I do.
Yes. Amazing. Thank you both of you really for a really inspiring talk. So can I next come to Emilios, who's a child and adolescent psychiatrist and also the CEO of Creative Tech Trust and Creative Health. So thank you.
Thank you. It's great to be able to go after you guys. That was fantastic. So there've been some excellent presentations today highlighting the potential of digital creative health in practice. And having spent time with creative health leaders in this country and abroad, we're truly seen as the world leaders in creative health academically. And we also have the potential to translate this to on-the-ground projects and creative health tech. Yet, for us to get there, it raises a central question. Why have digital technology and creative health not advanced together as far as they might? It's not for lack of innovation, nor is it for the lack of need. I would suggest that the answer lies in large part in trust. By background, I work as a child psychiatrist, a therapist, and in digital innovation. Much of my career has been spent at the intersection of these worlds, particularly through creative health projects over the last 20 years. In previous APPGs, they've explored how to evidence creative health and extend its reach through new platforms and channels. And today we've seen how some of that has come and how far it's come. And yet, after more than 20 years working across these systems, my assessment is this: trust remains the limiting factor, particularly when working with children. It sits between creative health practitioners, the people and patients engaging with these approaches, and the leaders, commissioners, and policymakers responsible for enabling them. And importantly, it flows in all directions. Creative health practices through art, music, storytelling, and engagement with nature operate at a deeply human level. They build connection, meaning, and safety. They often reach people where more conventional interventions cannot. Over time, practitioners in this space have developed cultures and communities that protect that depth. So when technology enters, particularly where it's perceived as extractive, as commercial, or overly reductive, it's entirely understandable that this is met with caution. We see this tension in contrasts: evidence frameworks alongside exploratory practice, risk management alongside spontaneity, standardization alongside cultural and individual expression. These are not superficial differences. They reflect fundamentally different ways of understanding value, and especially what children need. There are broader forces shaping trust. Concerns around the human-generated content in training AI systems, often without clear consent or attribution. Concerns about the impact of digital social media platforms on mental health, particularly among young people, where the consequences have been profound. And a wider sense that opportunities for creativity are being reduced across society, from education to professional training, including within medicine itself. As a children's clinician, I do not take these issues lightly. Taken together, these create a context in which trust cannot be assumed. If we are serious about enabling creative health to develop, supported, rather than undermined by technology, then we must be equally serious about how trust is built. I would suggest two priorities. First, clearer ethical and economic frameworks for technology. This includes how value generated by AI is recognized and redistributed, particularly where that value is derived from human creativity. There is an emerging discussion around whether forms of taxation or levy on an AI-generated value may be appropriate. ChatGPT is having those conversations themselves. Such approaches would enable reinvestment into the very communities and practices from which that value originates. Second, protecting and promoting creativity as a public good. This is not as an adjunct to health, but as a foundational component of it. This means sustained support for creative practice within communities, within education, and within healthcare systems themselves. Alongside this, there is a responsibility on all of us in leadership, in policy, and practice to demonstrate what this integration can look like. In my own work within medical creatives, we're beginning to explore this in a number of ways. Through community-based programs, we are developing ecosomatic approaches for anxiety, supported by digital platforms in partnership with community creative health practitioners, intercultural roots. We are working across sectors with the USA Creative Food Company, Health and Wellbeing Through Food, looking at their Get Saucy products to understand how everyday products such as food can support both health systems and creative engagement in schools across the states. We're also contributing to emerging approaches that assess digital technologies, not only for effectiveness, but also for safety and harm. Following recent cases involving Meta and YouTube, there is increasing recognition of the need for more robust frameworks in this area. In response, we're developing methods to assess the potential harms of digital technologies in both adults and children, so that individuals, clinicians, and systems can have a greater confidence in the tools that they're used and are recommended and are being increasingly integrated into healthcare. And within my NHS role, we continue to develop the Waiting Room London social prescribing platform that connects individuals of all ages to community-based support, recognizing that these require careful curation and expert oversight, while working with academic partners to strengthen their understanding and their impact. These are still early steps, but they demonstrate what becomes possible when trust is actively built rather than assumed. So in closing, The question is whether we can build systems in which technology does not erode safety or creativity, and innovation remains accountable to the people and communities it is intended to serve. If we can do that, then the opportunity is considerable. We can truly be world-leading academically and digitally, not only to improve outcomes, but to shape a model of care that is both effective and deeply human. Trust is not something we ask for, it's something we must design for. Thank you very much.
Thank you very much. I particularly like the supported, not undermined. So it's really good. Can I just introduce Lord Kamall, who's one of our officers in the Creative Health and actually sponsored this very splendid room. So thank you and welcome to you. Yeah. That's great. So thank you for coming as well. So last but not least, we have Alan and Pani, and you're well, you perhaps you could introduce yourselves, and then after that we're going to have a discussion. So welcome.
Thank you. I'll go first and then hand over to Pani. So I'm Alan. I'm chief executive of a digital health company called Polyatrics. And I'm absolutely stunned by all of the amazing things that have been developed and presented here today. I'm really interested in what you were saying, Emilios, and all of these issues that are being raised around not just creative health and creative technologies, but actually it extends to a lot of the innovations that are being developed and implemented locally and nationally. So we've been working firstly in London, but now predominantly in Hertfordshire, as well as nationally with the NHS in partnership, to look at addressing some of those key issues. Two in particular that have been raised, which is really in relation to this particular event, how do we capture all of these amazing innovations? How do we bring them together with all of the other creative health activities that are out there, and also with the other allied health sectors, so physical activity, education, the voluntary community, faith, social enterprise sector, and many, many others, and actually position them in such a way that they now become community health. This is what neighbourhood health is all about. And this is something that is not new. It's a concept that's been developing probably over the last 10 years or so. I like to think that we've been kind of ahead of the curve. It's the NHS that's catching up with us now. But the solution that we've been developing has been led by Professor Samir Gray, who has been focusing on a system approach to bringing all of these different organizations, all of these different opportunities together. Everybody can have access. That then raises another issue of how do you get all of these amazing services out to patients and the public. And that's really where I particularly have been involved. And we've developed the digital technology to support that. Now, the concept was not mine. The concept actually comes from the NHS. And they described an online digital portal where the NHS number would be used as the unique identifier. And an individual's own NHS data could be used to surround them with all of the information, education, services, activities, technologies that would really empower them to take far greater control of their health and well-being, and also to better self-manage a lot of their long-term conditions. And this is what we've been building up, particularly in Hertfordshire, but we did a lot of pilot work in London during the pandemic as well. And we've been very privileged to be able to work with some really, really clever people who really understand the impact that these things have. And it's absolutely crucial, I think, going forward, when we talk about moving services out of hospital and into the community. What does that actually mean? What does that look like? And if we're looking at a process of disease prevention and population health improvement, how do we deliver that? How do we engage with the population? And obviously, digital is absolutely key to that. And the NHS recognises that but I don't think necessarily that the NHS has a clear understanding of what that ultimately would be. So we've kind of been given our head. We've been told, go away and develop all of this, because we're not quite comfortable in doing that ourselves. And I can understand that. We've developed up those processes. We've developed up the technology. We're going through some of the regulatory processes right now, and we will be rolling this out in Dacorum and Hartsmere, which is one of the combined neighbourhoods in Hertfordshire, one of the first wave of neighbourhoods to be part of that national neighbourhood implementation process. The impact of all of this, I think, is better coming from Pani, who's a GP and actually is more responsible for actually how this is actually going to look and feel as we go forward.
Thank you, Alan. So I'm Dr. Pani Sisru. I've been a GP partner for 31 years in Hertfordshire. I'm the GP Federation Lead for Southwest Hertfordshire, and I'm a neighbourhood clinical lead. So a few jobs out there, but I'm still working very actively as a GP. So I'm going to try and bring it to life from a GP perspective. And I think GPs are closest to the community that will benefit the most from the WISH technology. Quite simply, in my view, the WISH is game-changing. It allows clinicians and their patients a complete connection to services available locally and nationally for their specific health condition. And for the first time, we'll have full knowledge of what's available from voluntary sectors, including arts and culture, community services, activities, sports and leisure. And we'll be able to use that to wrap around each individual's needs based on their health record. We've never had that. So we will offer a complete package of care, not just drugs. That's what it feels like at ground level, that all we do. We're drug dealers, but we can prescribe so much more that affects someone's life and health. A clinician can choose to follow a patient's efforts if they want to gain better control of, as an example, their diabetes by allowing that specialist diabetes nurse to interrogate the WISH platform to see what the patient has or hasn't done based on the advice that they were given the last time they saw that nurse. And that's a big incentive for that patient. It does encourage them to then follow up and make that bit more effort. Or the patient with newly diagnosed Parkinson's disease to be told by the neurologist or the GP that we've got locally available to you the Chiltern Neuro Rehab Centre. They can fully support you. They're based just around the corner in RAF Fulton. And that offers all sorts of help to that person who's newly diagnosed. And it's not just the drugs that they're doling out. It's that really special advice. And the reason I brought that one up was because we had a presentation from the specialist Parkinson's nurse based at the hospital trust who didn't have a clue it existed. And there's no way, it's not a criticism, there is no way people, clinicians can keep up with what's going on out there in the real world, what's on offer. But it's a fantastic service. I visited it. So in this way, information is actually pushed and flagged on our clinical systems, so we can't miss it. And we can actually print it out and offer it in the same way as we do a prescription. People want knowledge. That knowledge should be backed by the NHS. They like that. And it's on a platform that's trusted. And that should be the NHS app. And it will be. It will be on the NHS app. People will feel empowered to take better control over their health by enabling them to identify those activities such as music, art, sport, exercise, green open spaces, interests that might interest them and they'll follow that, and they can join in with others who have the same interests using that platform. And that's what really improves their health and well-being. This wish is a directory of directories. I would call it the NHS fountain of knowledge. And I'll say it again, the wish is game changing. Thank you. Yeah.
Excellent. A really good range of speeches, and yeah, well done everyone for speaking in Parliament and putting across your points so well. I'm going to go to the audience, but can I just first of all go to Justin Varney-Bennett, who's with us, who's the Director of Public Health at DHSC. And I just wondered if you, I'm sorry to put you on the spot, Justin, but any quick words, and then we'll go to the audience.
Yes, thank you, Simon. So I'm the Regional Director of Public Health for the South West of England, but I'm also the Department of Health's lead for creative health now, hence joining you today. I mean, a couple of reflections. I mean, I think we are in a really unique space. I mean, when I trained, much like you, Simon, some time ago, we used to have a pager and a fax machine. And I now have students, and Felix may not know what a fax machine looks like. Yeah. The rate of technological progress, the concept of digital art and digital creativity is completely different from when I was a young person and I was a student. And I think we've got to be generous that the NHS took 20 years to get to some of the very clearly evidence-based technologies like dynamic hip screws and statins for heart disease, even though we had a really good evidence base. So yeah, we're on the learning curve. And I think recognizing how fast that journey is. I think there is really interesting from what I've heard today, some of the reflections around digital as an opportunity of creativity to communicate, to engage, to help people understand their own health, and to use digital as a vehicle to support people, to empower them around their health and their well-being, but also to reach people that can't come in from face-to-face. And one of the great opportunities we have is digital allows us to get to people that we physically can't get in the same room. And there's been some amazing stuff, I think, shared today, but also I've seen nationally in that space moving it forward. I think it's really important that we do acknowledge, as Emilios said, some of the potential harms in the space and the risks as well. And that's also why the NHS, I think, treads carefully and cautiously, because it is learning how to be safe in this space and to connect. There are lots of opportunities, and the challenge always, I think, in this space is, and the broader space of creative health, is when there is so much on offer, when there are so many things we could help with, the NHS and policymakers struggle to hear, where do you want us to start? So I think one of the challenges, particularly in the digital space, is thinking about what is the key area of health to really focus and build a narrative around, so that those of us that sit on the policy side can hear that narrative more clearly. Because if you say it's great for everything and everyone, nobody engages. Too big an ask. Whereas if you say, let's really focus in immersive environments and people's understanding of mental health and well-being or pain, these are really specific areas that you can connect with. So I encourage people to think about how we take some of this in a really targeted way moving forward. But the potential is huge, and it will get ever more huge as tech continues to grow and evolve. And the challenge for us in the health space is both keeping up, but also being able to look over the horizon a bit more. Because some of the stuff that will be there in 20 years, we haven't even imagined yet. And what that will able to achieve will be phenomenal.
Thank you, Justin. That's really profound, and lots of really fantastic comments. And I was particularly struck with the Parkinson's, for example, you were talking about, because there's quite a lot of evidence that dance and Parkinson's are really, well matched in terms of treatment, and they're not medicines. And also we have got a crisis in this country, and 9 million people in England alone are on antidepressants. So that tablet route has been more than overused, I would say. So that's great in that way. So could I throw it open to the audience, and if you would like to say something, if you could just raise your hand, and if you could just say who you are first as well, which would be really useful. So are there any comments, or have we covered everything? So, Muir, would you like to say something?
You agree. I'm the chair of Little Longer Better, which is the NCCH program. So we started in the over 60s. It's what happened in Hertfordshire was moved up to other age groups. And the mission was to increase health and longevity. And really through promoting and enabling activity. So physical activity and individual compulsory walk to the Royal Society of Arts, the all individual walk after the city. But also emotional and cultural activity. This is where discussing with Pani, starting to collect from individuals. Imagine you were stuck in a care home, Somerset, or somebody in Hertfordshire. What's your favourite music? What's your favourite art? What would you like? And also things like talking about hobbies, where we born, what football teams. Because the good thing you love shot at Gingrich, you have to stay in Somerset. No one else would have had a shot at Gingrich. I don't say shot at Gingrich, but there are always people love shots at Gingrich. Well, probably 187 then talking about the care home. So what we'll do is put the judge of the music. Other people, chair the funding of it. And what we've seen in the last 15 years is expenditure on the NHS, which is the National Disease Service, very important National Disease Service, from 150 billion to 220 billion. Our local authority funding has gone from 70 to 79 billion. And the way into the view of this from your background, as you were planning out, we see that. So these governments speak of billions in the chest, billions in millions. The waste is huge, you mentioned, into the business. People coming in with private blood tests, people coming in with private living. And yet, if we could shift 10,000 tons of drugs, that's a hell of a lot of money to private inclusion. But I think something your help to do is that look at what was calling both programs like we did, not just NHS, and then giving people like families the responsibility and the opportunity to manage all the resources that is flowing from the resource population. So this is, I think, the art is significant of what we are almost all being chosen with discussions. But it's very equally important for 60, 70, 80, 90. So thank you very much for organising this. And thank you for what you did to launch the group of Skype. I think what you're doing was sort of 2,000 years.
Well, thank you for that. I mean, it is interesting because, well, two things come to mind. The first thing was we had a workforce planning session. And I went to that and I said, okay, so you can say how many GPs you have. Where's the funding for the workforce to make the preventative shifts? And they didn't really know, actually. They didn't really have an answer. So I've sort of certainly flagged that, whether they actually said in the end that will go down to the neighbourhood health centres, that decision. So that was a bit of a cop-out, I thought, in that way. And the other thing I would say, and I'd like to bring other people in, but what the other thing we're trying to do is get 1% of the hospital budget shifted into the community. It's like pulling teeth, I can tell you, because, you know, that's a lot of money. The 1% of it's about £3 billion. Getting that shifted across takes a lot of doing, and they have to lose it in the hospitals to gain it in the thing. So that's a tough ask, I think. So that we are in a difficult space but if we want to make those shifts, we've got to take money out of the hospital, actually, and and we need to put it into community care. And we need to put it into all the functions of which, really, including creative health. So we are challenged in that one. I don't know if would you like to comment on that at all? Or
I mean, certainly can't agree more. I've been involved in the ICB and the HCT, the Health and Care Partnership, and I'm on their executive board, and it is like pulling teeth. And in fact, if you look at the governance structure of these organisations, there is no GP representative on most of the boards. You look around the country, they're not actually represented as a single organisation. You have GPs giving their point of view as individuals general healthcare, but not representing general practice. And equally, although there's someone from the VCFSC sector involved in the boards, they don't really have the same voting rights on the governance structure. So bring a GP in, maybe an individual organisation, and we'll call it general practice, representing general practice. We bring the VCFC having voting rights within those boards. You start seeing a different conversation around how the funding's distributed. So that will help. There are other things we're doing, and we're involved in something called Proactive Care project, which we hope will go national next.
One of the interesting things is to get this sort of shift. So really a lot of the things that you've been proposing, all of you, we need to get it not on a prescription, i.e. when someone's become ill, we need to get it before that. And I think that's one of our challenges. How do we deliver to people that aren't yet ill? So we make a genuine national health service, not a national illness service. So, and I don't know, Justin, do you want to come in on that?
Yeah, I mean, it's interesting because I think one of the challenges is, and it is a perpetual challenge for public health, is how do you get people to invest in stopping something happening, and then it doesn't happen, and we know it doesn't happen because we did the thing, but something else filled the gap that was created. And I think one of the interesting reflections is some of what we've heard today has also been very heavily in the clinical treatment space. So it's not just the challenge of how do you get funding from secondary and primary care. It is also, well, we know it works in secondary care and we get better clinical outcomes, we're still not getting it in the clinical pathway. You know, even within the hospital, and when you look at the total number of art therapists in the country, I think it was about 700 and about 15% actually are employed in the NHS. There's a significant gap in terms of what we could do, even in the clinical management space, let alone the getting upstream space. I think also my reflection is a bit in that getting money out of the system and moving it around needs a much more open conversation about what is actually being paid for. Because when you try and, both there's a public discussion about, would you rather have a nurse or would you like 10 community creative projects? It's one or the other, there isn't the more money. But actually underpinning that is that the money of the nurse is also paying to keep the lights on and having to repair the walls, ceiling, etc. So I think there is a much more nuanced conversation around how do we shift money. But I also think there's quite a lot we can do within existing, where the money is currently sat. Are we maximising the evidence base as effectively as we could?
And something someone said about the supported and not undermined by the digital space. And then at the moment, if you put in a symptom of anxiety, you'll probably get linked to loads of suicide websites or whatever. Do you know what I mean? And so how can we sort of shift the online environment so that people go to helpful stuff, like all the stuff that you've been proposing? I don't know the answer to that. I just wondered what you thought we'd like to come in.
I think for me, that's where the creativity is really important, because I see when we talk about statistics, when we talk about on the point that you were making, regardless of technical knowledge that we may or may not have, it has meaning, but up to a point. And when we hear somebody's story, it resonates in a different way. I was just doing a workshop for a certain heart condition that is 90% prevalent in women post-menopause, very specific demographic. And there was a man attending. So suddenly that small percentage took on a different meaning because it was sharing the story, even for somebody that has been studying that condition for some time. And so I think in terms of appreciating what we as in a society can do or shouldn't do in terms of prevention, etc., I think that's where the creative intervention can be especially powerful, because it says a lot more than a statistic or risk, the really difficult concept to grasp, I think. Even we need to know what it means. So I think that's key thing to leverage.
What Muir was saying about like music in care homes, I think it's really, my mum is quite demented and she's going to be 90 next week, but she loves the Rolling Stones. They're quite old too now, actually. So, but if we could plug her into that, she's happy, and she knows all the words as well. So, Martin, do you want to come in?
Yeah, hi everybody. I'm Martin Marshall. I chair the National Centre for Creative Health. Emilios, you talked about regulation. I'm keen to understand, I guess, how the speakers think regulation might play out for your kinds of projects. Because some of the projects sounded quite low risk as far as impact on users might be concerned, others sound slightly higher risk. My concern, I think, is that the creative space is a risk-taking space, almost by definition, whereas the NHS is a risk-averse space that's very prone to over-regulation.
Yeah.
So I just wonder how we're going to find a ground that's conducive but does its job as well.
Yeah, but lady behind you, sorry. Yeah, no, you. Yes, yeah. Lady behind Martin. Yeah.
The microphone yeah. Professor Research Professor at Leeds University and lead of the Glowing Stars case study. Thank you for the invitation, Alex, and for the fascinating sharing of insightful views and wonderful projects. Let me just quickly not answer, but respond to what you just said. I think this is where research comes in. As an artist-based researcher, I gained quite a few ethical approvals from IRIS through the NHS ethics application process. I think that it takes two to tango, and I'm glad you're here today, because unless we find ways to support the artist, researcher, and all the creatives who want to deliver those wonderful projects within NHS, this is not going to happen alone. And it's not a criticism about NHS, because it's a healthcare medical provider. But for example, in the IRIS application, there are little things we can change with a recommendation if they made. So this does not require 1% of the budget to go to the creative, but it would make such a big difference because it would justify the importance of creative health and digital health when we conduct research within NHS. For example, on this question 95, 98 on the system, methodologies, quantitative, qualitative statistics, blah, 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 other. If we could add creative arts, digital, explain what kind of methodologies we do, how can we rigorously evaluate these projects so that we can find the right balance. I think this is really important. So if with your power, we could, make changes to create more accessible, inclusive processes within NHS, not just to welcome the artists, because they have very positive experiences of working with clinicians, but, help them not to lose faith and continue pursuing fantastic projects, doing research, evaluating, and improving patient outcomes. That would be good. Thank you.
I think that's a fantastic comment. I think, there is quite a lot of creative sort of type therapies online. I went to something at South by Southwest last year, and there's a whole stream of people coming up, presenting their little project around anxiety, etc. I'm sure none of them are regulated and been through regulation. So we mustn't kill this with regulation for people who are within the NHS space. So I absolutely agree with both of you there. But also we do need the evidence continually collected, I think, as well. So I think that's really important. And any further sort of comments? I was is there in the corner there? Yes. Could you come forward again? Do you mind? Sorry, it's like stepping forward and risking your life, isn't it? But, yeah, and if you could say who you were, that'd be lovely.
Hi everyone, my name's Sarah Tico. Lovely to hear all your amazing work and see lots of you again. So I'm the joint managing director of an organisation called the XR Health Alliance, and also the director of a multi-award-winning digital creative health experience called Soul Paint. It's been shown at places like the Lincoln Centre, won awards at South by Southwest. We've taken it to the United Nations and had great acclaim around the world. But it took 10 years to make that piece of work. And through that process, I saw a lot of the challenges for the digital creative health space, which actually led to the creation of the XR Health Alliance. During the last 5 years, particularly, we've launched 2 industry reports about the state of immersive technology, particularly in the UK across creative industries and healthcare and how we can bring it together. That catalysed a £20 million investment from UKRI called the Mindset Programme that brought together games designers and artists to create new interventions around healthcare, as well as create recommendations about how we can bring this together to create a new strategy. In November of 2025, we also released a landscape mapping report where we looked at 229 organisations around the country. They're actually deploying this in hospitals, universities, and what sort of organisations are creating these projects and collaborating with them. So I just wanted to share some very short recommendations that we found from that. So I think, as you were saying, I was really keen to jump into the regulation discussion because I think this is one of the biggest issues that we face. Currently, for a digital health organisation, it's a real grey area. So people say it's a wellbeing tool, we don't need anything, but we do. However, it costs about £2 million and about 2 years to go through that process. No one has the money to do that. And by the time you get through that process, your product is already out of date and there are already people that have leapfrogged them. So this is a real challenge that we have been actively exploring through creating an XR regulatory sandbox in Liverpool, which should be starting this year. And I think the challenges that we've seen is also around infrastructure. How do we deploy these tools in community spaces, in healthcare, and being able to link organisations? As we know, the NHS is not a whale, but a very large school of fish. So being able to actually learn and scale work that has successful pilots, I think is really important. And lastly, I'd really like to advocate for the possibilities of creating pipelines for collaboration. How do we bring together creative experts with ethics specialists, regulators, academics, and healthcare providers to co-create things in a meaningful way from the beginning, and creating infrastructure that enables that collaboration. Often someone might have a great idea, but if we collaborate with, say, an academic, they want to own all the IP, which is stopping collaboration actually happening. So being able to bring those groups together to co-create products that can be really helpful and impactful, and thinking about the pipelines so that things can be piloted and scaled and actually share this learning feels really important. I think that so much of the support that's happened so much has been around clinical interventions, which is why I was so excited to come here today, because I think this work intervention is so necessary, and being able to build on this together would be really exciting.
Thank you, that was really fantastic.
And it does, again, so I mean, who should be regulating? So it's an open question. I have no idea. Should NCCH be regulating, giving you a title? Simon, isn't it?
Can I just say, like, as somebody who's running an organisation that operates across 6 local authorities and different ICBs, works with education, we are being asked to be regulated by all of those organisations. We have compliance demands where they're all asking for different data in different ways. Even the local authorities, they are not the same. And what we're seeing is a real push of the offloading of administration to organisations such as ourselves, because those local authorities or ICBs are struggling.
So Simon, what would you suggest? What would make it easier for you to get regulated while keeping people safe?
I mean, a single point of regulation would be fantastic.
Okay, yeah,
would be great. I mean, and you talk about risk. I mean, if you look at our organisation through a certain lens, we're an organisation that uses social media, grime music, and works with really, really vulnerable young people. That's a very tricky ask to get across to an ICB. So the answer is in being able to demonstrate outcomes. But I think as a sector, we really struggle to do that. So, and finding ways to do that don't medicalise and don't problematise and don't get in the way of the relationships that we are asked to build in a room with young people or old people, whoever it might be. And those demands from whoever it might be, the local authority, for the data that they need, it's so often getting in the way of those relationships in the room at the very beginning when you're asked to ask questions that are not helpful in that situation.
No, I totally agree. Muir, do you want to come in? You have to shout or something, Muir.
I kind of this for physical activity, apparently, given the slightest hint to lawyers within there, within an industry of risk management. Firstly, we never use the word safety. Never use the word safety in 50 years in public health. It's all about risk management. And there is a major report on physical activities, and the title of the report is benefits outweigh risk, and the last 3 words in the report are benefits outweigh risk. So I think it's just a matter of collecting the evidence we've got about the fear of our existing benefits and the high risk to your own figures and antidepressants. The number of children being put in people, for example, the effect of isolation over the people. And I think it's we need to clear a consensus statement on benefits out of risk. Keep them all out of it. That would be that. If you look at broader law, want to get involved, well, that is a problem always. But I think it needs to talk to this, and the beauty of the law is the total body, which is the backing on it. This is the interest of we have to think to be really difficult. Reviewing the problem is that so many people have been over medicalized, armed by drugs, definitely the benefits from non-drug therapy, and benefits outweigh risk. That's what I think is good for it.
I think that's a really good point. And I often find that risk is about risk to the organisation, not to the actual participants. So that's what you're talking. If you want to actually say what it is, it's about risk of being sued, not risk to the young person or whatever. Can I come to? So there's someone back there, and then to just. Okay, Justin first, and over to you. Yeah.
Two quick things on this. I mean, one. So I remember back in the days of Public Health England, when there was the attempt to have an NHS app library. You might remember, I think it was called like the X unit. And it didn't last. The amount of energy that went in to try, and that wasn't regulation, that was simply recommendation for the NHS. So I think there is learning, and we're in a quantum different space now from where we were a decade ago in this space. But it is worth looking at that and what can we learn. And then I think Muir's point about physical activity is an area I've worked in for many years. There is a lot of learning around how risk and regulation become very quickly barriers to action. And there are easier routes around curation and recommendation and avoiding the regulation space. But that also means you sometimes have to avoid the money and funding space as well. And it's the trade-offs. The trade-offs in terms of where you get your money from and what you can do and the skills that it does happen. The final thing I would say is also, because we use these huge catch-all terms in the creative sector, so digital is a huge and diverse landscape of intervention. The risk around an immersive environment operated in a clinical pathway is very limited. That is very different from young people going onto a social media platform, and where we have very little control over the algorithms and the content. And that also speaks to breaking it down a little bit more and being a bit more specific within the spectrum of digital, which bits might need regulation and which bits might not, and thinking through in a slightly different framing of it to make it easier to get over those hills, I think.
Yeah, that's good. But yeah, gentleman at the back, do you want to come in?
Yeah, go ahead. If you want, I'll go after. Yeah.
Sorry, we should have a roving mic, really, but we haven't, not fixed mic. Say who you are.
My name's Tom Underwood. I work in the Joint Strategy Team in the Department of Health. Do a lot of work on health and work, but also physical activity and long-term interest in this space. Just a question about the evidence. So we've kind of talked about physical activity. I do think economic activity and work is similar kind of issues here and another number of others. Is there an evidence base around creativity as a social determinant of health? I'm sure some people in this room probably do. It sounds lots of headlines.
If you come at 5 o'clock, we've got a woman who's written a whole book on that, actually. So that's true. So I think we have. That was a good question 20 years ago. I think it's pretty nailed now, I would say. Does everyone else agree with that in terms of creativity? So I think, yeah.
Simon, as a social determinant of health,
right.
I don't think we've got that evidence nailed, even though we all believe it is, but I don't think we've got that evidence.
Yeah.
I mean, I think internationally the argument of the third domain of health in WHO, which is the bit that we conveniently always forget, which is about physical health, mental health, and then the third one, which is social health, which is the domain in which creative activity, spiritual activity sit, and the WHO recognised it as an evidence-based aspect of health. However, it is not particularly prevalent in any country's health policy. So it's a bit that, despite several decades of the WHO definition, it is the bit we forget. And I don't think we invest in that space and thinking. So I think there is an evidence base, but it's not framed in the same way that we would think about physical or mental health in policy.
Yeah, so that's helpful. And part of the reason for asking is because I do think, I said, I think physical activity, I think work. I'm sure there are some other similar ones which are, I think, largely from your point around, so being socially, economically, emotionally, physically, active. They're going through the kind of similar, I think, challenges that we just described. So kind of, you mentioned the benefits outweigh the risk consensus statement for physical activity. For work, there's the work as a health outcome consensus statement from the Royal Colleges of multiple medical colleges, and I suppose I just was wondering what that, it sounds like there's a bit of a kind of a similar gap here, and some of the applications. My question about how you would then apply that is, well, if that is good for health, then when someone engages with the health system, if they then leave without having had, so there's a kind of not what's the burden of proof at the moment feels like it's kind of on the kind of creative health side, as opposed to saying, well, actually, if we don't do something, if something, then their health is getting worse. And so it's a slightly different argument than necessarily maybe the drugs that are good. Hopefully I made that point clear, but I'm just trying to position this in relation to those, and it does sound like that kind of social determinant point is it feels like a gap where those other areas maybe they've got that at the moment. Not to compare or compete, because we're obviously the same thing.
No, it's always a good challenge, I think. And social determinants of health are manifestly very broad. No, that's the whole point of them, really, in that way. But no, really interesting intervention. Thank you for that. I mean, what seems to be coming out is a sort of feeling like I don't know. This is maybe a way forward. Maybe this group could list a series of recommendations that a creative digital offer gave, and you sort of self-regulate. Now, the House of Lords is self-regulating, so there is we can do that sort of thing. But maybe we can recommend that I don't know whether you around any sort of contact, and is that a possibility? Do you think you guys are do you think that's a because there's probably 10 recommendations you could come up with. I don't know what they are because I'm not specialist in this area. But what do you think? What would you say to that?
I think that it's important that we don't try to overly embed into the NHS and overly associate recommendations for creative health or anything else back with the NHS, because that's where the fear about risk and litigation starts to materialize. Pani is not an expert in physical activity. He's not an expert in creative health. How comfortable are you, Pani, at prescribing activity or prescribing creative health when the risks are that if something goes wrong, then you're the one that gets it in the net? So I think there are a number of different opportunities to capture creative health and make them available more widely, not just to patients, but actually to the population. The research that we did, and with the pilot program that we did, tackling older people in particular, by giving them the right knowledge, and this was the key. This is where Muir's work really comes into its own. When you educate people to really understand about aging, about physical, mental, cognitive health, managing long-term conditions, making those recommendations not about what they should be, well, not about specific activities, but making recommendations about what they should be doing, lifestyle changes, understanding the benefits, the consequences of not doing these things. That creates the motivation within the individual to go and find things. And if you can then take those things and present them as opportunities for that person to make a decision, actually, I quite like the look of that, I'd like to get involved with that. That's putting the onus on the individual and not on the prescriber or on the health service. So you're opening all of this up to the general public and to the population more widely. The response that we got during the pilot was huge. Just by giving people that knowledge and increasing their motivation to act, they felt hugely empowered to take more responsibility for themselves. That's where the pilot began to unravel a little bit, because actually we only had a certain number of things that we could actually offer to them because we were in the middle of a pandemic. So they were looking for more, they wanted more. But actually, in all of the feedback that we got, we were looking really at sort of activation by educating people, we're motivating them. By offering them things that we thought matched with their ability to do them, then they felt more confident. And actually, confidence is another area that we're talking about, because actually, when something is made available through an NHS platform, it's not a prescription, it's almost like the app library. Here are things that are available that you can try. Actually, again, people are far more inclined to get involved in a lot of these things. And actually, when it comes down to sort of activities or getting involved in creative health, they're quite willing to pay for things themselves as well. And most people can. So just one last thing is if we do go back upstream and start looking at people that we want to support in terms of disease prevention. So the NHS is already running health checks. So people over a certain age go along, they get seen by a practice nurse or by a GP, and they're advised, you know, your blood pressure is too high, your cholesterol is too high, you're a bit overweight, and you're at risk of type 2 diabetes. Here's a leaflet. Now go away and do something about it. Actually, if you can put them onto the NHS app and say, okay, so here's a health and wellbeing service, here's everything that we know about it, here's all the opportunities that are available to you locally where you live, and they're all kind of accredited because actually they're monitored, not managed, but they're monitored by the local government or by the NHS. Try some of these things. That's hugely empowering because they've got the confidence to know, A, I've got a problem, B, I need to be doing something about it. And here's what the NHS are suggesting that actually I might want to participate in.
You're suggesting in a way that people take their own responsibility for assessing.
Never use the word should.
Right. Never, yeah.
Give you knowledge about evidence for benefit, and we'll give you knowledge about local and digital opportunities.
Yeah, but they shouldn't, not necessarily. Yeah, no, that's good. That's good. Very good point. We'd like to come at the back there and then over to this lady here. Do you want to come forward? Sorry about this. You don't have to come forward, but okay, you go on then. Shout out. Good. Say who you are as well. Yeah.
It's not that one.
No, I'll be careful. Okay. Well, thank you for having me today. So my name's Paula Headley. I'm a music therapist by background and a musician, and I've worked in the NHS for 25 years. And I'm professional lead for arts therapies in one of the trusts, and also in another trust I work, Central North West London, is where we sort of developed this digital music therapy care pathway for young adults, so specifically from sort of 16 to 25-year-olds. I suppose one of the things I wanted to say when you asked that question, what would be a recommendation, I think, is to have a real cultural shift in education, which is around really celebrating and prioritizing creativity and engagement in the arts as really a powerful kind of learning tool, not just in terms of academically, intellectually, but also in terms of developing social skills, that sort of capacity to kind of emotionally regulate. I just think we don't capitalize on that enough, and schools are still places where children and young people, I know because I have a daughter, sometimes experience schools is not the right fit for them if they don't excel in certain subjects. I think we could do so much more there, and I think it continues in healthcare. So I've worked for 25 years. Children and adolescent mental health services, really, they're not conditioned to employ art therapists or not really linked into art creative health projects at all. And I was listening to the projects and the work you're doing and the job that you're sort of into and that you enjoy. It was really, really inspiring. And so I work in adult mental health services, and we had to kind of push to work to develop this link with child and adolescent mental health services. And they were really pleased for us to develop that link. But, you know, you said that the NHS is risk averse, but the government policy drives NHS policy. And why couldn't the government do more to really highlight the sort of added benefits of creativity in the arts in healthcare, and particularly in this forum for children and young people? I mean, you could diversify the workforce in sort of mental health services, of course, in other areas as well. But you could be much more innovative in terms of who you recruit in those town services, and also beyond. How do they link in? How do you use art therapists and creative art practitioners and third sector organisations to develop those links with people maybe that are on the waiting list in CAMHS for 2 years? You know, they're not being seen, and that's no disrespect to all of my colleagues encounter. You know, obviously I respect the huge work they do.
No, I think that's really important. I think it's also quite interesting that trying to think of what you're saying about schools and that sort of thing. So, I mean, it's almost outside the remit of this group, but we do need to promote creative activities before they get ill, which is what I've been saying. I've just come back from Brazil, actually, to look at the community health workers. And what they do is if they find an isolated person, be it child or adult, they get them together with other people, sometimes in a singing group, sometimes playing football, sometimes going to some music stuff as well. And that is, so they are identifying. And in a way, maybe we need to identify the at-risk people and before they get ill as a preventive way.
You've got NHS, sorry, because I really liked your presentation. You've got services within the NHS, like mental health support team, that employ art therapists actually, because they often do quite well in the role, but to carry out kind of more generic activities. And the primary form of therapy interventions offered, I think, is more linked to CPT, which can be really valuable. I'm not sort of arguing against that at all. But why can't, in those teams that are employed by the NHS that link up into schools, why can't they diversify their workforce to actually also deliver creative interventions for those children and young people in schools? So NHS and schools, we do interlink, don't we? I mean, so.
That's a very good point. I think that's excellent. Do you want to come in, Simon? Oh, sorry, you were next, weren't you? Yes, sorry. Could you say?
If you want
to. No, you go first because you had your hand up before. Sorry, Anna.
So just a comment on actually everything everybody's been saying. So I'm Dr. Shamla Rahman. I'm a neuroscientist and also an artist working with music and also theatre. Back in the midst of time, I did a PhD looking at the neuroscience of creativity. And so my life's work has basically been about how to actually link that kind of life sciences support towards creativity being really good for health. So I might disagree a little bit about the whole sort of not making the prescription because we can actually maybe have a recommendation to try and build on that body of work about the neurobiology of creativity and how it can actually link to longevity, for example, as well. And so just to also share some sort of challenges, which I think are kind of related to what you were saying as well. And, recently, there's been more regulations around looking at digital mental health. And if you're looking at MHRA, like when we're looking at digital, we have to apply for SAMD, which is software as a medical device. And that used to be not necessary if you're just doing, let's say, doing research at the level of, say, lab testing or small feasibility or anything like that. But now you have to do that. And it's quite a cost. It's quite prohibitive. So if we even trying to sit there and get this kind of initial validation in the very first place, how do we do that? So even from the perspective of, as soon as I use, say, GAD-7, that is considered super health rather than well-being, and I have to go and do a DTAC. And it's like, okay, there are all of these kinds of areas. Not only is it prohibitive in terms of costs, for say a company, or even from the academic perspective, it's also like, I didn't know that. How do I actually kind of bring those things together?
But can I just check them? So any digital intervention has to go through MHRA?
So at this point, especially if it's digital mental health, so it might be, if we're even looking at things like personalization, I'm working a lot with brain activity. So part of the thing is about personalization, but also utilizing bits of Gen AI. All of that is now going into, having to apply for the MHRA approval before you can go ahead and even do some little feasibility studies. And then it brings me to the next kind of challenge, which is funding. And then, there's certain kinds of funding that's only eligible for university-led research council-based sort of applications versus a company, let's say, through Innovate UK. And you really have these challenges of IP really coming into the foreground for that. The last thing really is kind of linking. I really wish that there's a relationship to which, UK wide. Is it? I would love to ask about that. Because how do we actually get these sort of digital solutions onto some sort of procurement pathway, for example? It's not really that obvious whether it is social prescription, whether it is through community, whether it is through ICBs, is that through commissioning? I hear tell there's actually a little bit of a down regulation in ICBs at this point. Is it through arts therapies? Do we need a standardization in some way?
or just a way of kind of signposting what are these different kinds of pathways for innovators, whether they're coming from the academic perspective or from the company perspective, to actually get this into the hands of people that need them.
Well, lots of challenges there, actually, rather than, yeah. The gentleman at the back, I'm quite keen to involve as many people as possible. So if you want to come forward. Yeah, thank you. Maybe you could just say who you are, lean close to the microphone.
Thank you. Yeah, hi everyone, I'm Andy Hall. I'm from CW Plus, which is the charity for Chelsea and Westminster Hospital. I just wanted to kind of pick up on some of those ideas and also come back to, I think Justin, you mentioned earlier about how do, this is a very fast changing environment. How do we keep up? How do we sort of horizon scan? And also maybe address some of these problems about, or the challenges of actually sort of getting into this space in the first place. So CW Plus has a very well-established arts program within the hospitals, but it also does a lot in the field of innovation. And we work a lot with some of the NHS innovation programs. So NHSX and the Clinical Entrepreneurs programs, for example. And a lot of these are sort of set up to help startups and small businesses find their way into the NHS and get started with those first pilots, and we'll give those kind of support. So it just occurs to me as, is there lessons to be learned perhaps from looking at the NHS approach to innovation, which we might be able to bring to bear here as well?
Yeah, no, it's a really good point, I think. And I think, everything that you described in your organisations deliver are all innovative, actually almost by definition, because they're in the digital space, but they're all really fascinating. So it seems like I'm just conscious we've only got 8 minutes left, and I think that's certainly something that I think we need to learn from how that works. I'm really keen here that there's so much enthusiasm and creativity in the room. We could kill this goose dead very easily with any sort of mention of MHRA. It gives me shivers, actually, because the MHRA is invented for chemotherapy and stuff, to regulate potentially very harmful drugs. The level of harm is small and the risk of benefit is high. So in that way, let's not get bogged down in that, I think. But it does remain the question, if a doctor or a nurse or any of us sort of suggest going to one of your platforms, how can we not be responsible for it? And also, how can you be safe and show that you are safe? So Justin, you had a
building on that, and it builds on Tom's point about learn from other sectors. So on the physical activity journey, that risk conversation has been much more owned by the physical activity sector. And the challenge, and it's a consistent challenge across creative sectors, is there aren't the governing bodies for sport. There isn't a governing body for digital in the same way. There is a question mark about the conversation with DCMS and Arts Council on how the digital sector views its space here. Because in other worlds, where we've done this on our physical activity, it's been very much a physical activity sector-led conversation within the way they self-regulate, etc., rather than the NHS owning it, because you do end up with MHRA or CQC or So I wonder whether that's the space to think about, is almost playing that back into some of the kind of governance structures around digital and going, how are you thinking about this, and where is it that we could bring the health conversation into the digital conversation to kind of mirror this the other way?
Yeah, no, I think that's really good. Muir, do you want to say anything on that?
I've had 400 bottles of pills, never met one. I've had not once about diagnosis, not once wrong. And I think we should be using the word negative, any sort of negative, and not providing people with information and opportunities. We are shouting everything to talk about. This could be tell us we looked at how to do dementia. The Lancet Commission was not for 10 years, and to be 3 cases for it. I don't think any interest commission was relevant, never mind public. So I think if you do Alan's line, that there are knowledge business, not a true business. And they will know that I have today is what you're offering to the ways that have been described. So any choice is negative the number of children using an antidepressants and other sorts of drugs. We could summarize that and then we say the theory
You don't want to get the lawyers involved. You said that yourself, Martin.
So there's been a number of discussions about the relationship between the NHS and the creative health world, and I think you suggested that maybe we should keep the NHS at arm's length for all the reasons that we've been discussing, that you don't want to get sucked into a big bureaucracy. I think that would be a real mistake. I think the NHS has got a number of things to provide and learn. This is something the NHS needs to learn from other sectors, to be challenged about some of the things that it does badly. The NHS has got a lot of money, and 20% of it is spent badly, we know, and so let's try and get that into the creative health world. But most importantly, I think we won't engage health professionals unless we bring creative health into the NHS. And whether we like it or not, health professionals are an incredibly influential group with patients, with communities, and with making a difference to outcomes as well. So I think we're going to have to play ball with the NHS, and we're going to have to accept some of the bad things, or at least negotiate some of the bad things that partnership will bring.
Yeah, no, I think that's a good point, Martin. Woman over there, yeah. Sorry about this. We helped our roving up. You get to sit at the big table, don't you? So that's very exciting.
Hi, I'm Flora Kelly. I'm the Creative Health Programme Manager for South East London Integrated Care Board. So again, sitting right at the intersection of creative health and the Integrated Care Board, the NHS. I suppose just a really quick point to echo Martin. I think there's really something about how we bring that knowledge of creative health increasingly into the NHS and normalise it, I think. And it's about bringing the art of the possible through this as well. I've been sitting in my role bringing creative health and the knowledge of the system around cycling something together for the last 2 years. And there's a real willingness and keenness to work in this way, but there's also an ask for a roadmap. And I think that's something that particularly in this digital space we can offer, is kind of bringing this knowledge that we're feeling together and gathering together and sharing it back to the NHS to say, here's what could be possible and here's how we could imagine it together and here's the art possible together. Because I think that's what the NHS, in my experience, are asking for. They want to make this work, but they need support in understanding how they can integrate it, but what they're allowed to do in their roles, how they can think about different things creatively in their roles. They're really keen to, but they're looking for guidance from us as well.
No, that's a good point, I think. Thank you. And, I think it is, like you said, there's something like 1 million children on the NHS waiting list at the moment. Apparently, about 70% of them got query ADHD diagnosis. So that's an area we could pour into with a little bit of money. And in a way, politically, getting rid of a lot of a waiting list is going to be very attractive, I think. So we're trying to do that here with the South Bank Centre in a little limited project, to say, give me your waiting list and we'll try and sort it. But you'd like to come in on that?
One more thing, very quickly, I can keep it to myself. I need to share that actually the arts can save money. Yeah. And we should not, I know we could include using the word should, but we should not forget this. So one of the main arguments about digital and creative health and using creative arts methodologies is how we could make the arts as a constant provision integrated within NHS. Social prescribing and arts and prescription is one thing. Constant provision of arts-based projects to build trust, to create opportunities for people and mothers to hold their children's hearts, to use connection and creativity. It needs to be part of it all. And in fact, our study, the Glowing Stars, shows that we can reduce the cost of sedation for children having MRI scans by using digital apps to prepare them for MRIs. So, yes, we need to remember that. We can save the money.
Yeah, no, I totally think it's true. We need to persuade the right people. We'd like to come in.
Yeah, I think also just bouncing off other people's points as well, I think we need to not forget that actually the arts has an image problem. In this country in particular, I think people understand, the general population understands the benefits of physical activity. The general population do not yet understand the benefits of creative activity, and not just arts activity, creative professionals, absolutely. But we also need to educate teachers. we also need to educate the general population so that they understand the neuroscience of what actually happens during any kind of creative participation, what that is doing to their bodies, to their psychology, all of those things. There's a real image problem that we need to not neglect in this work, because even just the language that we're using in this room, I don't know about anyone else, but it's making my head just go bing, 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 bing. And I'm a fairly intelligent person. You know what I mean? I've been in this sector for 25 years, and I have to work hard to keep up with all the language that's being thrown around in here. We have. Sorry? We do, but we need to start speaking in plain and clear terms so that everybody can understand this. And that's where we get a shift in behaviours. That's where we get a shift in health systems and in professionals.
No, good point. I'm going to have to draw this to an end because the Prime Minister's talking about his vetting procedure, so I better go and do that. Anyway, look, can I really thank everyone who's contributed, and the audience has been very lively, and thank you to the online audience as well. That's been really, really useful to me. Very, very quickly, trying to summarise what everyone's been saying. There's something about how we regulate the digital space to make sure that people are safe, but we don't kill the goose. I think that's the first thing. And maybe what Justin says about organisations making sure that they can show that they're safe is the way forward, rather than we putting a load of things there. Bit about funding. Who's going to fund this? Where should it come from? We've talked about that and about a left shift in funding. Outcomes and knowledge. You were saying we must have that knowledge, and we must give the knowledge, and we must be a knowledge organisation, and then embedding into society, and then embedding it into the NHS. So they're the sort of things I've got from it. But we've got much cleverer people who will try and synthesise everything that's been said, and we'll come up with that's this lady up here apparently. Documents. And as I say, we'll circulate that to everyone who's here and everyone who's been online, and we will also take it to number 10 as suggestions to that. So can I thank everyone in the audience, and thank you very much.